Thank you very much for that introduction. It's very humbling to be here with so many great names, and I'm glad to have the opportunity to speak to everybody today. Let me get over here so I can share my screen. Is everybody seeing my lecture?
Yes, it does come through very nicely. Thank you.
Thank you, Dr. Maddox. So today I was asked to give a presentation on airway management and neck trauma. From my understanding, there seems to be somewhat of a need for this in the current conflict in Myanmar right now. Just wanted to get started and we'll see where we go. Just a little bit of background. I know that somebody else will be discussing the specifics of evaluation overall of neck trauma, so I won't go very much into detail with that. The main components in any kind of airway evaluation, and certainly with any trauma evaluation, is quickly assessing for any potential life-threatening emergencies. And in neck trauma specifically, that covers the potential and likelihood of a difficult airway, the need for assessment for deterioration that can happen very rapidly, as well as evaluating for any damage to nearby sensitive structures and preventing damage to nearby sensitive structures. And because the severity of these injuries can be quite high, the assessment needs to be very rapid, and the care for these patients can be quite specialized. In general, the priorities for any severe life-threatening neck trauma and neck injury is to secure the airway. As I mentioned before, the deterioration can be extremely rapid. However, the method and the time frame for securing the airway does not necessarily have to be the first component on the list, and doing it in a more controlled setting, if possible, is certainly preferred. Additional priorities are to protect the cervical spine. There are a wide variety of reports in the literature, as well as incidents of concomitant C-spine injuries in the right setting, and then continuing to evaluate for other injuries that may be involved beyond a potentially catastrophic neck injury as well. So moving forward with a general assessment, in the history, the major component is really to determine if there's any evidence of significant neck trauma, and that can be a wide variety of mechanisms, from blunt injury, that could be a hanging or clotheslining injury, to a gunshot wound, shrapnel, puncture injury, stabbing, etc. And the clinical picture may not be initially very obvious as to determining whether there is evidence of a significant injury, especially if seen early in the assessment, before some secondary signs may have developed. And a good mnemonic and kind of assessment tool to determine if there is an apparent life-threatening injury, is the 12 mnemonic, which helps kind of delineate some of the more obvious signs for neck trauma. And those would be any evidence of tracheal deviation or tracheal disruption, any obvious wounds in the various zones of the neck, if there are external markings, if there are contusions, obvious hematomas, if there are lacerations, etc. Additionally, any evidence of laryngeal disruption, so that would be dysphonia, somewhat of dysphagia, foreign body sensation in the neck, described by the patient, can be an indicator of a significant neck injury. Venous distension, similarly, if there's evidence of vascular congestion, and then any evidence of crepitus or significant emphysema can be an indicator of severe neck trauma. Similarly, these are, I'm sure we will be discussing these later, but the hard and soft signs of a significant neck injury, often of a vascular injury. But these would be airway compromise. So if the patient is stridulous or has a gurgling, agonal breathing, large hematoma, if there's significant ongoing brisk bleeding, if there's a neurologic deficit or air bubbling through the wound, all of those are highly concerning for a significant neck injury as well. Other things that could be noted would be subjective dyspnea, dysphonia, a large hematoma or contusion in the neck, if there's some underlying crepitus or hemoptysis noted, would also point towards a significant neck injury as well. So another component when evaluating the patient is whether the injury is blunt or penetrating, and the mechanisms can be similar. They can also, obviously be somewhat different, and the management and presentation can be wildly different in these scenarios as well. Blunt injuries, we look at and think of hangings, strangulations, direct trauma or blunt assault to the neck. More rarely, seatbelts and steering wheel injuries directly to the neck may result in blunt trauma and significant neck injury. And then clothesline injuries, generally in patients and athletes while running, can result in this as well. And as we can see in these photographs, looking back at our 12 mnemonic and some of the other hard and soft signs for significant neck injury, in this case, there's a clear soft tissue edema and contusion with hematoma in the neck. I don't know exactly if the patient was stridulous or had any other evidence of airway compromise at the time, but these would certainly be concerning signs for significant neck injury. Similarly, here, the anterior ecchymoses and soft tissue edema would be highly concerning, even if this patient was breathing spontaneously on arrival. Penetrating injuries can be somewhat more exceptional or striking on arrival, but these are any sort of stabbing injury, cutting or lacerations, gunshots and shrapnel. A significant anterior or lateral neck injury is going to be very obviously concerning for evidence of airway compromise. However, even smaller maybe less exceptional or more benign appearing wounds can certainly result in significant airway compromise in the correct setting. And that would be resultant from expanding hematomas or direct injury to the airway. So the general management, as I have alluded to and spoken about earlier on, the main component really for any significant trauma, including neck trauma, is continuing the trauma assessment while simultaneously preparing for any need for a definitive airway or that eventuality. The other components that are certainly important to consider are, if available and possible, to keep the patient breathing spontaneously. So that would be deferring paralysis and sedation for as long as possible. And then having a significant amount of assistance available if it is there. So having colleagues, lay people, anyone available around that can help if possible. Additionally, as I had mentioned before, inline C-spine immobilization may be required if the patient's C-spine cannot reliably be cleared or if the mechanism of injury and trajectory of injury is unclear. However, if the mechanism and trajectory is very obviously not involving the C-spine, then protecting the C-spine can result in more harm and airway difficulty than otherwise. And then moving on to securing the airway itself, pre-oxygenation, highly important, especially in anticipation of a difficult airway with the potential for multiple intubation or attempts. And then utilization of nebulized epinephrine, IV dexamethasone, when the concern is for significant airway edema, can buy some small amount of time while preparing for securing the airway. And then alluding back to keeping the patient breathing spontaneously, awake intubation and awake airway securing would be preferable. And then having equipment and personnel available for an emergency trach or crike is highly recommended as well. So more specifically for blunt neck trauma, ideally moving towards an awake intubation would be preferred. If video laryngoscopy is available, that can certainly be helpful, especially when the anticipation may be for edematous or somewhat distorted anatomy. However, if an awake option is not available, a rapid sequence intubation is a reasonable alternative to an awake approach. And then a fiber optic or a nasal intubation, a fiber optic nasal intubation is a highly reasonable alternative if the oropharyngeal anatomy is especially distorted from additional maxillofacial trauma. And kind of similarly, a blind nasal intubation is no longer recommended in these patients as it had previously been some time ago. It's been found that there's just a high complication rate and a high failure rate in these scenarios. And we can see on this in this graphic why even with a relatively benign exterior exam, the oropharyngeal and laryngeal anatomy may be severely distorted, and why keeping the patient breathing spontaneously with an awake intubation would be preferred, with a significant amount of hematoma in the right areoepiglottic fold, with significant surrounding edema as well. And if this were bilateral, or if this were to expand, having the patient being able to breathe spontaneously and find a position of comfort would potentially buy you very valuable time. Also, kind of additional options, a cricothyrotomy or tracheostomy are extremely reasonable and potentially necessary management techniques with severely distorted or edematous anatomy. Ideally, these would be planned if you know that the patient was severely edematous, if you had taken an awake look. But it may be an emergent procedure if the airway is unexpectedly edematous or distorted. And then these may be performed awake if the patient can tolerate that. However, if they cannot, or if they are obtunded, they may be sedated as well. The danger and the concern would be with severe soft tissue edema and anatomy distortion, that these procedures may be technically very challenging if the anatomy is too distorted to find landmarks reliably. And I don't think that I need to speak at length to surgeons about the management of a surgical airway, but for those of us that do not perform these on a regular basis, the emergency cricothyrotomy is can be an extremely challenging procedure, although the steps and the overall technique is relatively simple. And that's having the patient with an extended neck with a vertical incision approximately 4 centimeters over the larynx, finding the cricothyroid membrane, making a poke incision, widening that incision laterally, passing a bougie or the blunt end of the scalpel or your finger into the into that incision, and then railroading a 6.0 ET tube or a tracheostomy tube in place, and then evaluating for breath sounds and additional airway management from that perspective. Additional options would be a percutaneous cricothyrotomy, very similar procedure. That's just with, instead of an open initial laceration, finding the cricothyroid membrane and the trachea with a needle and a syringe first, and then using a Seldinger technique to pass a wire through. Can be especially challenging with a distorted airway anatomy and edema to find the trachea potentially, and then certainly finding the cricothyroid membrane. But this is certainly a possibility for management as well. And then finally, as a salvage method, the transtracheal jet ventilation can buy some time. This is a procedure in which a 10 to 14 gauge angiocath is placed over a needle into ideally the cricothyroid membrane, although most of the time it's directly into the trachea or nearby, and then attaching the angiocath catheter to the barrel of a 3 cc syringe that can then be connected directly to a endotracheal tube, and some oxygenation, minimal ventilation, but some oxygenation can be obtained through this, again, to buy some time. For penetrating neck trauma, very similarly to blunt trauma overall, high risk and likelihood of distorted anatomy for a difficult airway, both from the visualization and injury perspective. However, there is the I guess silver lining that the airway can be secured directly through the wound, which can certainly simplify the securing the airway in this scenario. But the airway management and penetrating neck trauma can certainly be challenging, even with an available direct injury to the airway itself, simply due to multiple wounds or retraction of the trachea into the thorax that can create a false track and complicate that. But overall, the management and securing the airway is extremely similar. So in summary, airway management and neck trauma in general has an extremely high potential for severe injury and a very high likelihood for a difficult airway. And anytime the anticipation is there for a difficult airway, being prepared for a surgical airway is imperative. And potentially having awake intubation or surgical airway techniques may be preferred to allow the patient to find a position of comfort and continue breathing spontaneously if that is available and within the skill set of the team.
All right, thank you so much. We have a lot of questions. I think I've been categorizing them. So in the interest of time, I think we should move on to Dr. Wilson's neck trauma, and then we can discuss all of the questions at once. So Dr. Wilson, thank you for joining us.
Can you guys hear me? Great. All right, let me try to share my screen here. And let's see, is the presentation view appropriate now? I can't see your faces, so.
Yes, it is.
Okay, great, thank you. All right, well, good morning, good evening, depending on your location on the globe. I just want to thank Dr. Davis for this opportunity to present, and I want to warn you that some of my information will be a little bit redundant, but repetition is a very effective form of education, or somewhat effective form of education. So things that you heard just now and hear me say will probably be helpful. And just to remind you, I'm a trauma surgeon, so I have a slightly different perspective on things. And some of what I'm going to tell you is opinion, and I'll try to make it clear. And some of just things I've learned from my experience, but I'll try to make this an evidence-based talk as well. So let's see. All right, so obviously I'm going to focus on penetrating trauma to the neck and not blunt mechanisms. You may see a few acronyms. I'll try to define them. PNI just stands for penetrating neck injury for the purpose of this presentation. So we talked a little bit about this already, but just to repeat, your initial assessment of any trauma patient always starts off with assessing airway, breathing, and circulation. And obviously in penetrating injuries to the neck, the airway can be compromised, which we just talked about. You know, and this of course is redundant, but it goes without saying that there are different techniques that you might need to establish an airway. The best technique really depends on the situation and the circumstance. But I would say that rapid sequence induction and direct laryngoscopy or video assisted laryngoscopy is still really the gold standard for establishing an airway. it's just super helpful to have some other technique that you're going to pivot to when this fails, particularly having someone who's comfortable establishing a surgical airway if you cannot get the view to pass an ET tube. Of course, other things to think about are resuscitation. So patients who are bleeding and present hemorrhagic shock need high volume venous access. Usually in trauma, we talk about a large bore IV in the upper extremity, but you really want to consider potentially putting your volume access in the groin in this situation. If you have a large venous injury to the subclavian vein for a zone 1 injury or to the IJ, you might lose all of your resuscitation through the injury. So this is one of the few times where we consider getting venous access below the diaphragm when we have a bad penetrating injury to the neck with hemorrhagic shock. And of course, secondary survey is always important, looking for associated injuries and really examining the neck wound to further delineate who may need to go directly to the operating room versus who can be observed and get diagnostic tests instead. And I'll talk a little bit about those hard signs. Again, we just saw a slide about that, but I think it ends up being pretty important. But looking for hard signs of vascular or aerodigestive injury, these are the patients who are going to need an intervention to help them. So moving on. So you've heard me use the word zones of neck injury. So just to review, the zones are really kind of defined really as you're standing at the head of the bed looking down at the patient. So zone 1 actually is the inferior zone. And then zone 2 starts at the level of the crike all the way up to the angle of the mandible. And then of course, zone 3 are very high or caudad penetrating neck injuries, which can be very difficult to manage when there's a vascular injury at that level. So, why do we have these zones? What's the significance of it? Really, the significance of the zones came out of a time where the management of penetrating trauma to the neck was very, very heavily operative. So this is just some data looking at the mortality rate of penetrating trauma to the neck during wartime conflict. And as you can see, the mortality started to improve over time. And one of the reasons it began to improve is the recognition that to help patients who are in trouble, they need to have their neck explored. So much so that by the end of the Korean War, the recommendation was essentially any zone 2 neck injury that penetrated the platysma, the standard of care was to explore and make sure there was no serious injury. The reason why it's zone 2 is because zone 2 is a relatively easy part of the neck to access. It's well tolerated. The patients don't have a lot of pain. Zone 3 obviously is very difficult to access without doing mandibular dislocations and things like that. And zone 1 injuries often require thoracotomy. But zone 2 is very easy to explore. And this really became the standard during that, probably I would say in the 70s, 80s, and even into the 90s. Of course, over time, people started to notice that there were a lot of these zone 2 explorations that were negative. So negative explorations were common in the days of mandatory exploration of zone 2 injuries. And these are data, and it's important to understand these data these are data based on arrival to the emergency department. So if you did not die in the field from your penetrating neck injury and you arrived to a place where you can receive definitive care, only 17% of, and I apologize for the jargon, only 17% of gunshot wounds, that's what GSW stands for, only 17% of gunshot wounds to the neck required an operative intervention. And only 10% of stab wounds will require an operative intervention. So if you explore all of these people, you will likely find you will have negative findings in many cases. So that leads to the question, how can we select the appropriate cases instead of just taking every zone 2 injury to the operating room? And it really depends on what you have at your disposal, right? So first of all, what are the hard signs of injury? So we saw a slide on this, but if you have one of these findings, really, you probably just need to proceed to the operating room relatively quickly, particularly if it's a zone 2 injury. Zone 2 injuries is going to be easiest and most advantageous to just manage these patients in the operating room. You can always get further imaging later on. And if you're fortunate enough to, like me, to have a hybrid room and you find something that you need an IR doctor to help you with, you can proceed to perform angiography in your OR, which is really, really nice. Although I recognize that I am operating with a great luxury that many people do not have. So patients with hard sign. So if a patient has a zone 2 injury and a hard sign, go to the operating room immediately. That's really still the standard recommendation for most patients. A patient with a zone 3 hard sign, if you have the ability to do angiography and they have vascular injuries, angiography might be the best thing for them, and or exploration as well. But again, it can be a very hard part of the body to explore. Often you will need a neurosurgeon to assist you. This is often at the base of the skull. It can be very hard to access. Zone 1 injuries with hard signs should be explored as well. Although if the patient does not show signs that they are in hemorrhagic shock, I would recommend imaging if it's possible to help operative planning. Usually zone 1 injuries are going to require some sort of thoracotomy to fully control a vascular injury. So it's nice to know what you're dealing with before you take that patient to the operating room. Without hard signs of injury, though, all penetrating neck injuries should really be observed or referred for some diagnostic testing, depending on what kind of diagnostic tests you have. So this is our modern management or selective management, selective operative management of penetrating injury to the neck. So, you know, what should that look like for zone 2 injuries? So observation versus diagnostic imaging, which should we do? So some would suggest that you only need to image those that have soft signs. So if the person is totally asymptomatic, you might just observe them. That can be problematic though, and for a busy hospital, you really don't have lots of beds to just observe people. And also you might miss some folks. And there's a 2006 study out of USC by Naba et al. That showed that the CT found vascular and or aerodigestive injuries in quite a few patients who were asymptomatic, who had no soft signs, certainly no hard signs. So if you have a CT scanner, particularly a high quality CT scanner, it's really the study of choice to figure out who needs an operative intervention. And often it can let you know that a patient could be potentially discharged relatively quickly, or help you figure out exactly how much observation they need or what other adjunctive studies they might need. So our BenTOB recommendation, and this is, you know, my hospital, of course, has a high quality CT scanner, have an operating room with an angio suite, a hybrid room that is. So these are our local recommendations for evaluation of patients with hard signs of penetrating neck injury. So CTA of the neck for really all stable patients with penetrating neck injury. So that regardless of zone, if you're stable, we're going to send you to the CT scanner to look at your neck. If you're unstable, of course, and it's a zone 2 injury, you're absolutely going to go to the operating room. And you know, even if you have a hard sign at this point, if you're stable, we may still elect to image you first to better characterize your injuries before we operate on you. The exception to this recommendation for CTA would be those with a very superficial wound that does not violate the platysma. And it really, you can sometimes tell, depending on the geometry of the wound, exactly how deep the wound is. And if you're confident that it doesn't violate the platysma, you can just repair that in the emergency department and usually discharge that patient. If your CTA or your CT scan is not reassuring, or it's not available, then consider operative exploration or further diagnostic tests. So if you don't have a CT scanner, but you have the ability to perform barium swallows or gastrographin swallows or EGD, that can help you rule out an aerodigestive injury. And then laryngoscopy, bronchoscopy can help you rule out tracheal injuries. Of course, ruling out vascular injuries is probably one of the things that's most important. But if your patient is hemodynamically stable, no bruit, no hematoma in the neck, you could potentially observe them if you do not have access to a CT scan. So operative exploration of the neck. I'm not sure exactly how many people we have who would be comfortable taking someone to the operating room in the audience, but I wanted to just draw your attention to, you know, the sort of the standard approach to exploring the neck. So generally our workhorse is going to be the incision that we carry along the anterior border of the sternocleidomastoid muscle. And occasionally, of course, we make collar incisions as well. Those are going to be the sort of our workhorse incisions for exploring zone 2 injuries. When you have a zone 1 injury, you often will have to extend that incision, perhaps into a sternotomy, perhaps a supraclavicular incision if you need it. I've really found myself doing all of these things when I encountered an injury that was difficult to control. So I think we heard a little bit about this earlier, but surgical airway anatomy, of course, should be emphasized and repeated. I think I saw in Dr. Fireball's slide, he had something that said, your finger can see. So if you're ever trying to do a cricothyrotomy, what you're going to encounter is often a poor visibility because it's a deep, dark hole. Oftentimes you lacerate a jugular vein, an anterior jugular vein on the way in, and you get blood in the field. And really, it's all about just making sure you can find your way into that space. And I've often found that, I wear a size 8 glove, so I have to use my pinky finger, but I've often found that my pinky finger is a great way to dilate up the tract and then also confirm when I can feel the rings of the trachea at the tip of my finger, then I know I'm in the right space. So if you encounter this problem where you need to obtain a surgical airway, obviously what I recommend is a vertical incision. If you can feel the cricothyroid membrane through the skin, just make your incision right there. If you cannot feel it, I recommend you make a vertical incision where you think it's going to be, and then you start carrying down your dissection with either sharply or sometimes with maybe a hemostat until you get the straps out of your way enough where you can actually feel the cricothyroid membrane. But as soon as you're confident that you've identified that membrane, you're going to sink the knife through that membrane, and then you're going to dilate up that tract with the back of the knife, in my case, the pinky finger, and then you're going to pass a tube. If you don't have access to a tracheostomy appliance, it's fine. You can use a pediatric, like a 5.0 or 6.0 ET tube, but keep in mind, you're already below the glottis. So you're only going to basically stick the balloon in, and you're going to have a lot of that ET tube hanging out. People often put the tube down way too far, and they main stem the 5.0 or 6.0 ET tube, not recognizing that this was designed to go through the mouth. So when you go through the neck, you only need a very, very small amount of that tube. Obviously, vascular injury is one of the things we get really concerned about. And the management of this and the surgical exploration for this is going to usually be, as I said, the sternocleidomastoid or anterior SCM incision, the standard incision we would make to do a carotid endarterectomy. It's our workhorse incision, and it gives us really good exposure. This is just another view of the anatomy. One of the maneuvers that you may have to do is, as you can see on this picture, you can see in blue the interior the jugular vein, and if you see the facial vein has not been ligated, but it's sort of been left open. But I would recommend you ligate the facial vein if you're trying to expose the arteries. And as you can see, it'll let you get the vein laterally out of your way, so you can really look at the carotid vessels and also other important structures like the vagus. So some important questions that come up, and some of this I've already seen in the chat. So the first question is, hard cervical collar to protect a possible unstable C-spine injury. So my observation, my recommendation, and I think I'm not alone in this, is that a collar in the setting of penetrating trauma to the neck is probably unhelpful. So first of all, an unstable C-spine injury is essentially ruled out by a normal neurologic assessment. So someone who's shot in the neck, particularly if they're shot in the neck by a single projectile, it's very hard for that projectile to take out both the anterior and posterior column and create an unstable injury without actually also hitting the spinal cord. So while, if you're shot twice in the anterior column and the posterior column, you could potentially create an unstable injury. The probability of that is very low. And I find that the collar gets in the way of assessment and management. So I really recommend that people not apply collars to penetrating trauma to the neck. I think it really gets in the way of your assessment, and I don't really think it ends up helping anybody. So that's my recommendation and what I've seen in my lifetime. Should you probe the neck wound to evaluate need for surgery, right? So you're looking at a neck wound, the neck you don't see any hard signs. Maybe I'll just stick a probe, a cotton tip applicator, or a finger in the wound and see how deep it feels. My recommendation be that you never do that to evaluate the need for surgery. That you probably, it's okay if the wound is a slash wound to sort of spread the wound edges and see how deep it is, but you never really want to stick anything in that wound, because if something has stopped bleeding, like the internal jugular vein, and you disrupt the clot, you may have a problem that you cannot control. And I would recommend that if you are in the in the emergency department evaluating a patient, you not stick anything in the wound, and also never remove any impaled weapon or foreign body. A knife sticking out of the neck, that, in my opinion, that should be removed in the operating room. In case on removal, the patient gets unstable, you're able to intervene quickly. And then this is probably one of the more controversial topics. So you have someone who's bleeding out of the neck. What's the best position for that patient? The reverse Trendelenburg position, or also known as having the head up. This is actually kind of, this is a difficult question. Putting the head up will reduce your venous pressure and will slow the bleeding, but it also increases the potential that you might entrain air into the vein. And that raises the potential for air embolism. So I would say that if you cannot control the bleeding, it's too brisk and it's in your face, and you really are not able to control it through any other technique, you probably should put the head up. But generally speaking, I kind of, if I suspect a venous injury, I really want to make sure that I don't entrain air into the vein and end up letting that air go to the heart. And by keeping the patient's head down, you make sure that you have some pressure in the jugular vein, and it doesn't allow air to entrain as easily. Also, in that position, if air does entrain, it's more likely to stay in the right ventricle, right? Because that's the position that we would put patients in for air embolism. But obviously a difficult topic. Let me look at my time. I think I had a few cases that I was going to go through, but I'm going to ask Dr. Davis to guide me if you would like me to go ahead and wrap up or spend another 5 minutes talking about the cases.
Yeah, we have quite a few questions that we've accumulated, so it might be good to just move on to our discussants.
Absolutely.
But thank you so much. I tried to copy and paste them into the chat, but it's not letting me do that. So I'm going to share my screen, even though that is a little bit, it's just a Word document. So I apologize for that. But just so we can all have an idea of what we're talking about. Can you guys see all these questions from the audience? Yes. Okay. So I'm going to say Dr. Nunez and Dr. Maddox, if you want to have any specific comments before we start in on these questions, and if you don't have any specific things to say, then we can jump in and try to knock as many of these out as
I have one question, and then I'll answer it. You come across a patient in the field who is comfortable sitting up and looks pretty good. You lay them down to put them on a stretcher to move them to the next facility. They say, "You're trying to kill me." And they sit back up. What are they telling you? They're telling you that they have chosen the most comfortable position in the field, and to put them in a position of uncomfort, especially if they have a transected trachea from a clothesline injury. They very well could die. So until you know what's going on, let the patient choose their position of comfort.
That's created by, if it's say like a zone 1 injury, for instance, and they could be below the sternum, they could have something like a cardiac tamponade. You just can't quite rule that out, and they often present the same way. They don't want to lay down. They're very anxious because their heart is being compressed. Thank you, Dr. Fearbaugh and Dr. Wilson, for 2 really exceptional lectures. The only thing I wanted to add that may not be addressed here was a practical tip for doing a crike. The best advice I ever got, and I've used to some good effect, is that with obviously any surgical procedure, one of the most important things we can do is have good retraction. And so while your knife is in your dominant hand, with your non-dominant hand, really getting good retraction laterally both ways on your incision, assuming that it's a vertical incision, which I think most recommend, that can minimize your blood loss with good firm lateral retraction, getting down to the cricoid membrane.
All right, sorry, I apologize. My internet is kind of coming in and out, but we can start with the first few and just try to go rapid fire. So the first couple are kind of related to when it's appropriate to start an emergency airway or either a tracheostomy or intubation, and when do you not want to do those things, and how many attempts at intubation should you have before starting a surgical airway?
I'll jump in. I think the most important thing, I think, in any trauma and any sort of really high pressure airway situation is to establish that airway quickly. It's something like a penetrating trauma situation, or even blunt, when things are hitting the fan and time is of the essence. In our institution, obviously, we'll have trainees doing establishing an airway, and I'll use my judgment and step in rather quickly. I won't, I'll allow the trainee a chance at the airway. If it doesn't go well, I get one shot, then I'll make sure that their supervisor or some attending physician is getting the airway. As far as the surgical aspect of things, I don't have a cutoff, but always have my equipment handy, which is, as Dr. Fearball said, and Dr. Wilson, just at minimum, a scalpel and a clamp to dissect with. In my mind, if I'll look for trends more than hard numbers. If things aren't going well, then I'm quick to step in and start setting up. I want to be right there when it needs to happen, and things are trending the wrong direction, I'll begin the procedure. But as far as numbers go, when I see those stats declining from the 80s to the 70s, I'm getting started already.
Mr. Maddox, don't forget that breathing problems may be secondary to a brain injury or a cervical cord injury. A high C1 or Atlanto dissociation, Atlanto-occipital dissociation can cause the cord to be cut, and then the person cannot breathe. The one skill that everyone should be able to do, and it will be variable, is intubation. And not everyone can do a surgical airway. Bleeding and airway are the two things that a neck injury can cause people hurt. I would like maybe to go around the room. A question came: what surgical text that's affordable can help me in managing this kind of injury? So Dr. Davis, why don't you start and tell them books that you use, and other people, including our international colleagues. What books have you found to be helpful?
Well, on my shelf right now, I have the Trauma Manual, the ICU book, Trauma, of course, by Dr. Maddox. Top Knife I have, Sabiston Textbook of Surgery. I don't know what other things that you guys would recommend. All right, we only have a couple minutes left, so let's just quickly, when would you not recommend fiber optic nasal intubation? And if you intubate through a neck wound and you get clot in the ET tube, what are some maneuvers for that?
Sorry, Dr. Nunez, you can go ahead.
Well, I think if you're concerned about facial fractures, and your fiber optic nasal intubation will cause nearly the same amount of trauma and friction as without fiber optic intubation. So certainly, if there's evidence of facial fractures, it's to be avoided.
If someone wishes to become famous, I noticed that someone mentioned Top Knife. Top Knife has been translated into 10 languages. It has not been, it's been most recently translated into Arabic and to French. It's not been translated into the most common languages of Thailand and Myanmar and that area of the world. So if someone is interested in such a translation, you can become very famous, and your university can become famous, and you can contact Dr. Davis or Dr. Wilson or I, and we can help you.
All right, just some quick questions to Dr. Wilson on neck injury. When would you do a barium swallow? Why do you need to locate the facial nerve? What kind of neuro exam would you do in a time and resource limited setting? And then if you get shrapnel, have a shrapnel injury in zone 2 with significant emphysema, any tips about that?
Okay, let me go as fast as I can. So a barium is a very sensitive test to rule out an injury. So if I have a low suspicion of injury, but not a zero suspicion of injury, is when I would do a barium swallow. If I have a high suspicion of injury, I think the best thing to do is take the patient to the operating room. In the operating room, I may do an EGD before I actually explore. But if barium is a nice way to rule out an injury. And then why do we need to locate the facial nerve? I'll be honest, I don't spend a lot of time worrying about the facial nerve. When I'm operating on neck injuries, that's usually above where I'm located. That said, if your patient is not an extremist and you can avoid injuring the facial nerve, you can find it. I think it's important to try not to injure it. And in my old days of doing parotidectomies at the Massachusetts Eye and Ear Infirmary with Dr. Fagan, he would make sure that I would not injure that structure. It's what neurologic exams should be done in a resource and time limited setting. I mean, it's the same neurologic exam that you should really do for every trauma patient, which is rough and dirty. Make sure they can move all extremities. Check their GCS score, which helps you to determine who can protect their airway and who cannot. Specifically for the neck, you want to make sure that they don't have evidence of a spinal cord injury. So you want to make sure that they can move everything. And the patient who's obtunded, you might not be able to determine that, but hopefully you can do your basic examination. There's more subtle things that can be injured in the neck, i.e. you can end up with a recurrent laryngeal nerve injury or a vagus nerve injury, which can lead to paralysis of a cord. But that's I would say that's something to sort out down the road and get the patient out of trouble initially. And then I would look at shrapnel in zone 2 like I would any other projectile, whether it's someone shot with a high velocity round, someone stabbed, whatever it may be. I would say that if they have significant emphysema, that is a hard sign. And I would take that patient to the operating room to explore and probably remove the shrapnel as well. As you know, particularly if I didn't have time to image the patient, I would definitely want to take that patient to the operating room. Now, zone 1 injuries, zone 3 injuries, not maybe quite so quick to the OR, but zone 2 injuries really should have a low threshold to just proceed to the operating room. It's an easy place to explore. It's fun. So go do it.
Very, very quickly, do you prefer a vertical or horizontal incision? What kind of suture do you use on the trachea, and any comments on trachs performed by non-surgeons? To either Dr. Nunez or Dr. Wilson.
Yeah, I'll just quickly, I mentioned a vertical incision. It's because if you guess wrong about the height, you can extend the incision. If you can feel the surface anatomy at the beginning of the case and you know exactly where you want to be, then you can make a transverse incision. But if you cannot feel the surface anatomy, it's too distorted by hematoma, a vertical incision is your best friend to extend the incision. The question of should this be performed by a non-surgeon, I would say if the patient is dying and doesn't have an airway, anybody should try to establish a surgical airway. Don't let your lack of experience let someone die if you cannot get an airway through any other technique. That said, it's preferable that someone with experience give it a shot. And then what suture do you use on the trachea? Most would recommend absorbable suture, just like you would for any other mucosal surface like Vicryl, or some might recommend PDS. Any other thoughts, Dr. Nunez?
No, Dr. Wilson, right on the money.
All right, and then Dr. Fearbaugh or Dr. Nunez, just a couple questions about awake intubation and C-spine. Any precautions that you take? How do you choose medications, manage gag? And then in terms of protecting the C-spine, can you use a sandbag and other recommendations for doing that?
Specifically for awake intubations, precautions mainly are trying to balance the degree of sedation with their ability to maintain their own airway, which is the idea. So generally speaking, my preference for awake intubations in terms of medications is ketamine, since that largely does allow for spontaneous breathing. People generally tolerate awake intubations pretty well with kind of sedative dose ketamine. There's always the very small risk with any concern for additional intracranial injury for kind of mild increases in ICP. But I think that if you're doing an awake intubation due to a catastrophic distorted neck injury, that getting the airway secured would probably take precedence there. And then topicalization with lidocaine or other local anesthetic, if available during the intubation attempt, can help reduce gag and kind of increase their tolerability as well.
You'd be added that as long as there's time, you probably want to be doing these sorts of things in the operating room with all of your adjuncts available and ready with your knife sharpened.
All right, thank you guys so much. We appreciate everyone who attended. Just send any comments or suggested topics to either my email or my Twitter, and we'll be happy to include that on the schedule in the future. Thank you, Dr. Host, Dr. Nunez, Dr. Maddox, Dr. Fearbaugh, Dr. Wilson. We appreciate all of you. So I hope you have a happy and safe day.
Thank you.
Thanks, everyone.